I had just few comments when we look at it, because Ola, sometimes we go to Europe and look at our European colleagues' perspective. So for them, transplant is approved, paid for by the government, and the overall cost or financial toxicity they find transplant is less compared to some of the newer drugs and continuous 3 and 4 drug over a period of time. So that is one perspective to keep in mind, how the same data, those who are transplanters still feel like the transplant is important, is wedded to more than one aspect of it. That's number one. Number two, we have also learned now in myeloma, and it came from Memorial Sloan Kettering studying the solid tumor patient, that this elderly patient, when you look at the non-myeloma component, and you look at many of them have what is called as CHIP, or clonal hematopoiesis of indeterminate prognosis. What we are saying is, we are now, when we send the bone marrow to Foundation Medicine, we get back, they have TET2 mutation or DNMT3A mutation, etc. So it may come to pass. These patients may be someone who have to be careful. You cannot expose them perhaps to an alkylating agent, high-dose therapy like melphalan, and then put them on maintenance therapy with an IMiD. Maybe they are the ones who could develop a secondary leukemia, etc. So my feeling is, we need to do some homework there, so the population statistics, like retrospectively going into CIBMTR and pulling up and putting out there, we have to keep in mind that the treatment, the prior therapy, everything is changed over time also. So that should also be kept in mind. And the people who do the transplant, we have long-term data. We have cured 10 to 15%. Looking at Arkansas data, looking at the French IFM data, we have proven it. None of these novel agents have still 15 years KRD data yet.
So, question, are we approving drugs prematurely? When we don't have even progression-free survival data, let alone overall survival data, are we approving drugs prematurely when we don't know what the benefits are? We do have, as you point out, data showing the benefits, the survival data of transplant data. How do you, as an oncologist, in this era when the FDA is increasingly approving drugs based on limited amounts of data,
but we have the accelerated approval program from the FDA.
But that doesn't give you the data that you need to talk to patients about what their likelihood of benefit is.
But I do think these are obviously very important aspects here. But I think Sundar brought up before that the data we have from the real world show that every time there are new added drugs to the field, that's reflected in the real world data with longer overall survival. There are multiple studies showing that the approval and access to drugs just keep on extending survival. So if you think 20 years back for myeloma, the average survival was 2 to 3 years. I mentioned before, I think the projected overall survival today is 10 to 20 years. That's 10 times more. That's unbelievable.
So fair enough. So the FDA, in requiring us to do triple combination therapy versus dual combination therapy, isn't helping advance the state of the art in understanding which drugs are more effective. If we wanted to understand what was best for patients, we do triple to triple combination therapy, head-to-head trials, right?
But those are not the trials that the FDA require for approval.
But if you want to treat a patient and I want to pay for that and the patient wants to receive therapy, at least my impression is that we're operating with less and less data to help inform the patient and inform you about what optimal therapy is. Would you agree with that? So your point is, and I agree, that triple therapy is better than dual therapy, quadruple therapy is better than triple therapy, is better than dual therapy. So what's the end game? Are we going to be looking at 5 drug combinations in the future because we'll get greater MRD negativity with induction therapy in these patients? Actually,
I would argue the other way around, because the science on understanding the depth of response, all the trials are doing MRD. It is in the benefit of the pharmaceutical industry, clinicians, as well as FDA, to really understand the depth of response. So it is becoming routine, right? You have been, after going to many committees and meetings, to say that the MRD should be really incorporated. While it may not be the drug approval per se, but the MRD is now pretty much incorporated. And as you know, as we are doing MRD, I'm doing MRD in my own practice to tell me what I should do next. as we get the MRD and we are getting even better, I shouldn't say even better, really good drugs in the pipeline, which to me is total surprise, because usually you'll get diminutive returns over time. You know,
Finding that fourth or fifth
as
drug,
you
yeah.
get the drug fourth line, fifth line. So if a drug, you know, used to give 50% response, you know, with, you know, Revlimid 60% response, when there was no IMiD, then the pomalidomide came, it came down to 30% or so. Then you get another drug coming in, you know, selinexor, for instance, it also gave 26% response, and that drug was just recently approved. So you always thought it'll be diminutive response, but there are some drugs which are coming in, or immuno-oncology therapy, bispecific antibodies, you know, dual antibody, or targeting CD3 on one side and the tumor cell on the other side. And then there are CAR T cell therapy. And these are, in a unmet medical need situation, is producing responses almost greater than 60%. You know, one drug, antibody drug conjugate, is in front of FDA with a 60% response rate, and the others are, you know, with, especially with the CAR T cells, you are talking about 90% response. So I have a feeling that once these kind of effective drugs move forward, the depth of response, MRD negative, you don't have to add more drugs anymore, you know. So the melphalan stem cell transplant was not adequate, and as he clearly pointed out, at that time we used to call it VAD chemotherapy. People wouldn't know VAD. It's vincristine, adriamycin, dexamethasone induction. Now we don't use it, and the younger generation doesn't even know how to administer it. So, you know, but now people know VRD. So my feeling is, like, as the new drugs come in, actually I should assure you, your life will become easier, not more complicated, and we oncologists won't be jumping in and adding more.
I like
We'll
your
actually
prediction.
less.
I hope it comes true.